Okay, so need stamina for the day today. And the next session, we're going to talk about some of the issues that hospitals have had with implementing certain pieces. There are some parts that are harder than others, and there are decisions to be made about how you're going to implement different pieces of the RED process. So this is the list. We won't go through that again. So if you implement Project RED, what are the outcomes? And we'll talk a little bit later about outcomes, but improved satisfaction, greater perceived readiness for discharge, decrease in hospital utilization, and increased PCP rates. But some of the challenges are that there are patient challenges. The patients are sick and they're in the hospital. There's frequent interruptions on the floor that when you try to do the teaching, as you know, you go into the room and the resident comes in, the attendant comes in, and somebody else comes in, the medicines get given and all that sort of stuff to disrupt the process, which takes more time. There's limited time, and that we all are concerned about the ill patient coming up from the emergency department and not so much about the relatively healthy person who's ready to go home. And the environment is not always conducive to teaching for the reasons that were brought up earlier about confidentiality, et cetera, and the patient's roommate sitting there, and we're talking about their diagnoses and medicines and that kind of thing. There are also hospital-related challenges. Resources are always an issue everywhere in terms of how to spend the extra time. We try to minimize it with the software that is being produced and some efficiencies that we're talking about, but resources are an issue. Changing the culture of hospitals, and that means that maybe the ward secretary, administrator would have to do some duties different than what he or she had done previously. Maybe the resident staff would have to do something in terms of entering information into the software during the process. Maybe the attendings need to do something different. And there's always the pressure to fill beds. We need to get patients when they're ready to go. We want to get them out of the hospital as quickly as we can, and that time of discharge metric is something that hospitals look at, and anything that slows that down is an interference and interruption with what hospitals can do and want us to do. There's also issues regarding the medical team that you're working with, and that for the medical team in general, historically, up until very recently, the discharge is low priority. And who gets to do the discharge paperwork and the discharge summary? It's the intern, right? So the lowest person on the totem pole is the one who has to put together all this relatively complex information to do the discharge summary. So guess what? Discharge summaries aren't very accurate and all sorts of mistakes, and clearly documented that that's the case. And also in terms of summarizing and synthesizing the case, how can we put a care plan together for this person so they don't come back? Interns really are not in a position to do that, but traditionally at most of our hospitals, that's the person whose job it is to organize the plan. The last minute tests, the last minute consultations, always throw things off, and are challenges to discharge advocates and to the nurses who will be doing this work, and how to appropriately discharge someone when at the last minute somebody decides that we're going to bridge the Lovenox, or we're going to do this new test, or the new test came back and things change. Are challenges and barriers to doing an efficient and good job. And inaccurate medication reconciliation is the hardest thing to do, is medication reconciliation. It gets somebody to sit down, and whose job is that exactly, to be sure that the medicines are the right medicines and they're the ones that they're going to be going home on in a timely way so that they can be taught effectively. And then communication issues always. As we talked earlier today, there's all sorts of different players interacting in and around the patient, and getting that team to effectively communicate is a real challenge. And of course, lots of patient-related challenges in terms of not having a primary care provider, limited insurance coverage, et cetera, money for medicines and for other things that they need to do to take care of themselves, low health literacy, language issues, substance abuse, behavioral health, pain, inconvenient for them because they want to leave often, and mobility and isolation, that they are often not able to do some of the things when they leave the hospital that we would like them to do in terms of appointments, et cetera. So what we're going to do now is to kind of go through, and we're going to sort of be interactive about this. So go through some of them, not all the items in the red checklist, but to think about how you will be doing each of these components at your hospitals. For example, component one is make appointments for follow-up and tests. Some of the challenges are listed here. Limited insurance coverage, doesn't have a PCP, availability of the PCP, discharge on weekends or holidays are difficult. Those are some of the challenges that you're going to be facing, and we could brainstorm a whole lot of other challenges too that make doing this difficult. But as part of Project Red, and I think part of good care, it ought to be done. And as I mentioned this morning, there's a whole lot of hospitals where people come in without a PCP, they go home without PCP or a source of follow-up after discharge. And a hospital does not see it as part of its job to either arrange for that or to get people back into the source of care that they have before. But we think that it's important. And if it's important, we need to figure out how to do it. So the question is, how are you going to do it?
Yeah, I think what we'll do is start off with, because I know we do have some barriers with that, we'll start off with Maureen in the back, and she can basically tell us how this gap is being filled at the moment.
So how many hospitals are represented today?
We have 1 hospital and 9 CBOCs, which are...
Can we write down?
Oh, thanks, sir.
Could we write down could you write down just all the hospitals? Yeah, that are represented today. Because it could be that, we'll go hospital to hospital and see what your thoughts are. So Palo Alto. You chose the person with good penmanship. That's good.
Northern Cal. And San Francisco. So in Palo Alto, to get the patients their follow-up appointments, we have an actual order set for them, for the residents and interns. So as soon as the resident knows that this patient needs PCP follow-up, doesn't have a PCP, they'll set an order in which comes directly to me. And what I do is I research what he needs, and I'll make the appointment hopefully long before the patient leaves the hospital, so it's in part of the discharge paperwork that the patient gets. If the patient doesn't have a primary provider, we'll go ahead and assign him one. Okay. If the patient doesn't want a primary provider with us, we'll go ahead. We have a special clinic called a discharge follow-up, which we'll offer them at that time too. Okay.
Just for process, could we on this slide, could we say the name of the hospital and what the strategy will be briefly? In this case, it will be discharge order sets. It sounds like that will capture some of that. So what is your position at the hospital then? So these will all be going to you?
I'm the discharge appointment coordinator.
I see. Okay, that's good.
So for holidays and weekends, what I do is I start prepping the acute teams that the holidays coming up, we need to know what these patients need so we can get these appointments made long before the weekend or holiday comes in.
This is the VA.
This is Palo Alto.
Palo Alto, yeah. And there is a position called the discharge appointment coordinator. Most hospitals, I would say, don't have that position, right?
So I'm part of the RIF, which is the referral case manager, which I have an active list of all the VA's RIF people, and I go ahead and I'll send them a secured email saying, we have your patient, he's leaving, and the discharge team has asked for follow-up care X amount of days. It works right now with Fresno, Reno, and Northern Cal. I would say 80% of the time they have the availability that we need for the patients.
So it sounds like the challenge is 20%. Additionally, I think the challenge is getting the appointment before the patient actually leaves 100% of the time.
Sacramento VA follow-up appointment.
My
name is Jacob Noor. I'm a Sacramento VA. So our follow-up appointments is we changed the process. Basically, have empowered our work clerks to do the follow-up appointments. In the past, we used to send emails and call the primary care clerks to do these appointments. But at this point, we have empowered our ward clerks in each unit to do all these appointments prior to discharging patients. So that 24/7? No, we don't have it 24/7, but weekends, they can do it over the weekends. The only problem is if they don't have a primary, a PCP, then we call the primary care offices, and then the clerks there set up that appointment for them.
Is it a problem getting appointments sometimes or no? Is
The
it a problem finding somebody to see them?
No, I think we've been pretty effective
Yeah.
in doing that, except for if they don't have a primary care, then that's a problem. And some special clinics, there is an issue that we're still working on.
I see.
But setting up an appointment with a primary care has been pretty good.
Yeah. I think that's a big advantage. I think the VA has advantages in many different areas compared to a lot of hospitals. Having appointment coordinators is a terrific thing, and not having difficulty in finding, people to see patients who are discharged is also a good thing. So Sacramento ward clerk set up appointment prior to discharge. Okay. How about San Jose?
They're a CBOC. They're dying to be an inpatient center, but they're not.
Okay. And San Francisco? No? Yeah. Oh, okay. So there's no discharge coordinator?
No discharge appointment coordinator.
Mm-hmm.
So if a patient is going home and they don't have a PCP, then they put in a consult through a order, and a PCP set up for them.
Okay. By the ward staff?
By the ward staff, yes.
The secretary or something?
Yes. Or medical clinic, or in the surgery clinic, they're ward clerks.
Okay. Okay. I think we'll go on to the next one, and then you can do that one. Okay, so that's great. Thank you very much for that information. The next area that hospitals have some difficulty with is follow-up plan for the results of pending tests at discharge. So some of the problems are agreement about who's responsible for identifying what those tests are. Is there a system and infrastructure to support it? At our place, we use Sunrise Clinical Manager. It's the system that we use. And the tests that have been ordered that don't come back, there's a way to click to see those results that are still pending. And the residents can go into that and see that, and then copy that onto another list. So is that an issue?
Well, we can have Carol Germani's a case manager, and she's just dying to give some information on that.
For follow-up plan results, the case managers work closely with the medical teams and the physicians to find out when the patient's going to be discharged. We identify whether the patient's going to need home skilled services or placement, and coordinate with the appropriate people so that there is a plan in place when the patient... Oh, pending lab results?
Yeah, if somebody has an endoscopy and they have a gastric biopsy and that's the result's not back at the time of discharge, is that somehow flagged that you're able to identify that test is still outstanding so that somebody can follow it up later?
Usually the physicians, the attendings or the physicians are the ones that usually follow up for those kind of procedure results.
That won't work.
I'm one of the hospitalists. That's done totally ad hoc.
Yeah.
Every time it's recreated and decisions are made on the fly.
Yeah.
Who's going to actually take ownership? And oftentimes I would say no one takes ownership.
Then the success rate won't be 100% where we like it. It will be somewhere down here. Yeah. Like everything else like that, when nobody's responsible for something that there's gaps. Sometimes it gets done terrifically and other times not so well. So setting up setting up a system, a fail-proof system for identifying when those tests are there and to somehow get it into the after-hospital care plan would be a great advance somehow. So what is the best system for each hospital?
Although it doesn't speak to the system, the VA has a national policy that the inpatient provider, if the result isn't back yet, is responsible for it. So there is kind of national policy that speaks to who's responsible, but doesn't get that, just kind of falls through.
Yeah.
Policy, but no
outside
process.
The VA, I don't know if that's policy or not, but yeah. That's great. Yeah.
He always does
legally,
that.
that's important.
I'm not trying to sidetrack, but there is at least one CBOC representative here. I see their representative up there, and I represent some outpatient work in Martinez, part of the Northern California. We're starting this PACT program. Are you folks kind of interacting? Because this is one way that there could be a bridge over to primary care. I mean, for these types of things, there's follow-ups. We're supposed to be following up at least 40% of our primary care patients when they've been in hospitals. We're supposed to have our own nurse case managers or a member of the team, interdisciplinary team, contact that patient.
Yeah.
So this type of thing could bridge together, but I don't know how I'll address that.
So we haven't, it's still a challenge for us, and we haven't bridged that gap completely. And so that's why I had the case manager speak to it. But no, so definitely it's an area where we need to improve.
San Jose does not want to be an inpatient center, trust me. Yes, we're implementing PACT, and we have RN care coordinators in our clinic, and they do get a list of the patients who are discharged, and they do make follow-up calls. We are not anywhere near 100%, but as Maggie Donius can tell you, if the tests haven't been followed up on oftentimes, that's where they're picked up.
Does your electronic system help you to identify that they're even there in the first place to be followed up later?
The test or the... You mean...
But if you look, you can find it.
Yeah, like when I'm making the discharge call, I'll look to see, are there any lab tests that have been ordered? Are there any x-rays that have been ordered? Sometimes the patient will tell me, usually it's their wife, they were supposed to be seen by such and such, or they're supposed to be seen by the such and such, but we don't have an appointment. And so then it becomes then my responsibility to generate that appointment. And it's usually a specialty.
Okay. Right. Okay. So identifying that the test is pending, getting it into the after-hospital care plan, and then getting that to the PCP, and then it's their job. And the patients also, by putting it on there and telling the patient that you have some responsibility to be sure that this test gets checked, and you have a discussion with somebody about the results, that it's at some level your responsibility also, I think.
I do think, Keith, I don't know if you want to speak to it, but you're already doing the GDOT team, right, from inpatient to outpatient. Are we addressing then, I've ordered such and such that will be done for them to follow up on the outpatient side?
So we're basically piloting a system where we use the PACT teams, and there's a mechanism in our secure email where you can send a message to the entire PACT team, the entire care team. And so the inpatient team will send a message to the PACT team regarding the patient's discharge needs, but that's completely non-standardized right now. So it again still is pretty ad hoc. It may be me sending a message to John that I'm going to follow up on something. It may be that he's got to follow up on something. It may be that my resident's going to follow. It's like the triple option play where there's a lot of risk for fumble.
Right. Yeah, fumbling. Yeah. So there's opportunities for the implementation team to hear some of the ideas from some hospitals and ideas from other places and put together a strategy for your hospital relative to this component. Okay, now moving on, how about identifying the correct medicines and a plan for the patient to obtain them? seems to be an issue at a lot of places. This gets into the med rec issues. And some of the challenges, of course, are the complexity of the medical regimens, the timing of the final medication reconciliation often happens at the very end, often doesn't happen. Ensuring accuracy of the medication list, communicating with the team, collecting information from several sources of data, tracking, coordinating, communicating changes in pre-hospital, in-hospital, and post-hospital medication lists. So there's lots and lots of challenges and lots of communication that needs to be kind of broken down. I don't know any place that does this. No one has really cracked this, not satisfactorily. But maybe if you have some ideas that you could share about how you do it at your place, or ideas of how you're thinking of doing it relative to a new state-of-the-art transition program, as an opportunity to do that. So.
First of all, I was at a Beacon conference, and they suggested changing the spelling of MedRec from REC to WRECK. Just a thought for future. But Keith, I've heard some hospitalists discussing med reconciliation on the inpatient side. Do you want to see what our process is now, or?
Sure. So we have I will say that I think that this is a place for improvement for us as well. That we have discharge instructions document that generally, again, the intern prepares that has a section for medications the patient was taking at admission, and a section of medications to stop, and a section for medications new medications to start. But it's quite non-standardized. It's created it's not auto-populated. It's basically built up from the inpatient. It's an attempt to put together inpatient, outpatient records, kind of smashed together. It's often actually updated at the last minute in a way that's not very transparent.
Right. Like so many hospitals. You're describing what happens most places.
Yeah. So, I sound like I'm saying that we don't have much of a process, because I don't really feel like we do have much of a process.
He's part of the ARC Collaborative, so he's got some work to do.
We all do. At least you're doing the work. A lot of places aren't.
How about San Francisco?
An enormous amount of credit for thinking about the issues and trying to set up strategies to address them.
Well, for San Francisco, we have the discharge instructions where all the medications were, done by the intern, and we just go by that.
So the intern does it on admission, and then at discharge, this is what we run into is, at discharge, the discharge advocate, who do they actually talk to get the final word on what medicines they should go home on? Often, they'll talk to the intern and say, oh, I got to talk to the resident. The resident say, oh, we got to finalize that with the attending. And the attending says, oh, I don't know, do what you want.
I think one of the keys to that, what you were mentioning earlier, is them being part of the team, and we're really trying to build that on the inpatient side with the case managers, really, aligning them with a specific team as well as nursing, and of course our discharge coordinator will be doing the same, because if you're on a team, you're all speaking the same language, you're pretty confident of where you're at throughout the day.
Speaking for the acute inpatient psych side of the house at VA Palo Alto, we have a process where, of course, nursing does teaching, but also the pharmacists will come in. If they're discharged within that standard business day kind of time frame, anything outside of that, though, when people leave AMA, then it's not a real smooth process, because sometimes they're going without meds. When if you've been on acute inpatient psych, now you have the ability to leave AMA, still doesn't mean technically that you don't need meds, right? You still need the meds. So that's a breakdown, I think, from our side of the house there.
Right.
And have you worked with any acute inpatient psych specifically? Okay.
No, but there's been a lot of requests about that, because with psychiatrists, even like big groups of ambulatory behavioral health groups have asked us, could they, and the answer is always yes, and they then go on and do it themselves mostly. But because in mental health, the issues are adherence to appointments, adherence to medications, then this fits that as well as, as inpatient medicine.
The process over at the Sacramento VA is similar to the Palo Alto system. The pharmacy is primarily responsible to do the discharge medrec, and it's the nursing staff kind of reiterate and reinforce that. We also do the post-discharge calls within 48 hours. So we ask patients if they have any issues, any questions in regards to their medications, and they're encouraged and referred to the advice nurses also. So those are the things that we have in the system.
We'll come to the phone call later, but who does the phone call?
We use a Title V. At this point, we don't use an RN or we don't use a nurse at this point.
A nurse.
So we have work clerks that do it. We don't necessarily have to answer questions in regards to medications, but they basically direct them to whoever. If there is an RN, they could direct them to the nursing staff. They do it right there. If they have any questions, if it's clinical, then they refer them there. Okay. And they could also refer them to our discharge coordinator or planner.
I see.
So whoever could answer their questions.
We were at one hospital. I can't tell you where it was, but it was Brownsville, Texas. And that this is
that camera rolling? No.
Oh, is it? And that is an enormous problem where I think that leadership is necessary sometimes, because the nurses, the way that MedRec was done there at discharge was that the attending would come in and discharge the patient, usually private attendings from the community, and write discharge. It was then the nurse's job to go through the record, see what the admission medications were, go through all the consultant notes, go through the record, and put together the list of medications. Honest to God. And then fax that to the doctor's office, and then in between patients, the doctor would get that list, cross it off, change this, change that, fax it back. Nurses were all upset, of course, because they had to do all that work, and then the patient, of course, wouldn't leave till mid-afternoon after the whole process was done. And then, I think in situations like that it takes the medical, the chief medical officer or leadership at the hospital at some level to say, when you write the discharge order, you have to write down the medicines the patient's supposed to go home on, and this is policy at the hospital. But at that point, it was a really very difficult for them to make those private doctors do that level of care. So that was a big problem. It was also in terms of making appointments. So and also discharge summaries, comes out in a second. The discharge summaries were done at 30 days, and again, it takes some sort of policy from the chief medical officer to say those discharge summaries need to be done sooner. So the nurses were very, very happy to say those doctors, they need to write the MedRec out when they write the order for discharge, and they need to do the discharge summaries right away. And I said, okay, who's going to make appointments? Can't be us. We can never, we can't change our behavior, but everybody else has to change their behavior to make this work. Maybe that's human nature. Yep.
I just want to make a comment in the Palo Alto inpatient medicine side that the case managers every day during the weekday are rounding with the team. Yeah. We each have one team, and in the afternoon when we round with them, we are going over the discharge list for the next day. Yeah. So we are anticipating discharges the evening, afternoon before, and that's also when we tell the house staff to start thinking about writing discharge instructions, to start thinking about the medication, and it really should not be waited till the day of discharge to decide on those things.
That's great.
And sometimes they are reluctant to consult with the attending, but the attendings are on call 24/7 when, when they are.
Right, it's their responsibility.
When they're attending on the team. I mean, of course, within reason, but sometimes they're very reluctant to talk to them at 9 o'clock in the morning. Oh, we have to wait till 11.
Yeah.
I mean, so we're making some progress.
Yeah. So I think it's it's great that you're able to round with the teams. I'm sure that's a very big help, and maybe that's something other places could think about doing. Also, if you had software like the software that was presented, you could talk with the resident staff and in the days up to discharge, you could say, please continue to update the software so at the time of discharge, it's almost done at that point. They could do it that way rather than just writing it down in the notes and that kind of thing. It would be a place to capture it and organize it.
Mary, do you realize you threw Dr. Posley under the bus in front of everybody here?
I was going to just ask San Francisco, I think you guys are having your PACT nurses be a part of the rounding, I believe. I don't know if you can comment on that.
Our medicine teams round every day. Our surgery teams just once a week, and then the other teams once a week only. But I'm a discharge planner, and the PT, OT, and everybody else are there. And we don't have the PACT nurses. We used to have them before, but because of, I guess they're busy, that's what I was told. They don't come anymore.
I have a question, and for you, or maybe for Dr. Posley. What, because we certainly have patients that can be on, when you look at meds and supplies, more than 40 items. And so some of those things, like everything that the dermatologist ordered, for example, typically the admitting team doesn't want to deal with that stuff. The patient is still going home, and I think sometimes there's a question there, well, what happens to the creams, the eye drops, the suppositories, how is that dealt with?
Yeah, that's a really good question. Any thoughts about that? There are certainly a lot of patients that go home with a long list. There's no question about that. And do you throw out the baby with the bathwater? If you have a whole long list, or should you just focus on the new medicines or the medicines who have had changes in them, and focus on the high-risk medicines? Or once you have the whole long list, things get, not as much attention can be paid to the things that really might matter. Sorry.
Yeah, I mean, I completely agree with that. I think that's a big problem we have, in that you have these, I would say the average list of the patients we discharge is greater than 20 items. And if there's one new medicine in that 20-item list, I think there's a good chance that's not going to be apparent to the patient or the person that's giving the education to the patient. And you may spend time focusing on the creams and rubs and not on the new antihypertensive they're supposed to be taking for their heart failure. So I think that's a big process issue. On the other end of the spectrum, when I attend on the ortho service, the only new medicine is the Vicodin. and so that's where so there's got to be a happy medium, and the Colace. That's Vicolace. So I think there should be some sort of best practice there, and I think this is probably something you would know better than me, that's sort of an emerging science in managing discharge, and how do you actually build the perfect med list?
Yeah.
Patients like ours that have such lengthy lists at baseline.
Yeah. Yeah. I don't think we know. I think that's part why we want to, I think this kind of activity is really worthwhile, to see how some hospitals do it and other hospitals do it slightly different, and we can learn from each other. We're at that stage of the evolution of this whole art, I don't think anybody has really nailed the best way of doing that. We err on the side of completeness. That might not be right.
I was going to just say that part of the benefit of starting the discharge process from the beginning is that you really get a sense of what your patients know and don't know. And so if, and I picture our two discharge educators in my head when I'm saying these things, but if Lynn knows that she's been on this patient has been on the medication for 10 years, like, she can make that a lower priority. She knows she's taking it correctly already because you've gone over the medication list with the patient before you're doing the discharge education. So it's a process issue, yes, but you'll know what's new, old, and what your patient knows already before you go in for that last interaction.
I'm almost wondering if the list couldn't be populated chronologically. So something maybe that was ordered for the last 10 years is toward the bottom and all new things are at the top, or something like that. The question is, do we break it out supplies versus medications? So in San Francisco, supplies are at the bottom of the list. It's that way everywhere, isn't it? Pens.
What if those supplies are critical? Like colostomy bag supplies or wound care supplies, because this is where the readmission risk soars. When those supplies are an important part of, the aftercare management, and the next thing you know, the patient's back because they didn't get those supplies and things fell apart for them.
Just to clarify, when we say at the bottom of the list, we don't mean at the bottom of our priorities. It's just that on the printed list we get, they're at the bottom.
I think that's also kind of theoretically that part of things get relegated.
Anything else about MedRec? Any other ideas or insights or?
Clearly you need the supplies before they leave the door or something, but if the patient's going to use it when they get home, they either have the colostomy bag or not at that point. So if it's on the list, it having it at the bottom may help versus what are the meds they're taking if it's meant to kind of be for the family to look at later. It seems like breaking it out by new ones. I don't know. I wonder if some people in the VA have it set up, but we'll see what Nebraska. They'll be our answer for everything. See what they do.
Yeah, at VA hospitals, are patients able to get a supply of their medicines before they leave the hospital? Across the board, yes. That's such a huge advantage over most places. Most places that just can't happen. And then there's the whole thing about, if they don't get the right thing, they can go right back to the floor and say, I didn't get this prescription. That happens a lot. I don't have the slides about what happens, at the 2-day phone call. Or maybe we do go over a little bit, but not getting the prescription. It's on the list, but the intern didn't actually give them the script. And then going down to the pharmacy, they go to outside pharmacies, most patients, most hospitals, and for whatever reason, it can't be filled. It needs a prior approval or something about the insurance or a copay that they don't want to pay. Huge problems with that. Also on that list is patient intentional non-adherence is a really big deal. And there are many patients 2 days later say, I knew when they gave me that medicine I wasn't going to take it. And what do you do about that exactly? It is. It really is.
The ability to actually know what patients are doing when they leave the hospital.
Yeah.
When I practiced at Stanford, the patients would leave the hospital and you had no idea what was happening, and whether they'd see their doctor, where they'd get their medicines, where they'd go, and it really felt like you were practicing in the frontier.
Yep.
And I think that we don't leverage that.
Yeah.
Really well, that we actually know what the patients do
Right.
with our orders and with our requests.
Yeah, you have all the elements of an accountable care organization, you really do, and that you have such advantages to be able to have that communication, even to know when to get refills and things like that. Most places don't. Okay, last comments on MedRec? If not, then another area people have trouble with is how to produce and teach the written discharge plan the patient can understand. So one way to do it the way we used to do it is to produce the after-hospital care plan with a Word program, kind of freelance everything. And I would not recommend that because it's not efficient and it can't take 5 years. Now it's a matter of not just doing it, but doing it efficiently. Another way is with the software program that we saw earlier, which, if it's a standalone product, data has to be entered into it, print the after-hospital care plan, and teach it. And ultimately, IT information flows into it. You add a little bit, you print it, and then teach it. So what are you, David? What do you think the ideas are for the system?
So we've been really clear that we want minimal data entry. So we want CPRs to feed right into our after discharge plan because we're too vulnerable for errors if we start typing and putting things in and changing up names and that kind of stuff. So we are really hoping for the program to have the after hospital care plan, and it comes straight from CPRs. And I know that none of us, like I said, we know there won't be a switch flipped in 2 weeks and it'll resolve our problems. But that's our goal, is to have something that's automatically fed. And so far, the ARC committee that has gathered, we've gone through the after hospital plan, and we're thrilled with 90% of what's there, and thrilled with the ability to adapt what's there.
Right. And okay, what about the other half of this statement, which is who's going to teach it? Whose job is it? Are you going to hire a new cadre of health worker called discharge educator?
I don't think the VA is using that word at the moment, hire. Especially when it's tagged on with the adjective new.
Yeah.
But we are...
So in the absence of a new person, how are we going to redesign or re-engineer processes, change the culture of hospitals so that, is it the attending's job to teach the after hospital care plan? Is it the staff nurse, case manager, social worker, some combination, intern's job? And how are you going to do it? Not theoretical anymore, but how are you going to do it?
Well, I can say, how are we going to do it? So I can tell you what we've done so far is we have realigned case management. And before, some case managers had teams part A, part B, or all of A, part of B. Another one had all of C, part of B, something like that. And so what we've done now is aligned one case manager per team, and we've taken another FTE and moved that under case management, which will be our first discharge. We're calling it discharge coordinator, not advocate. And that person is then going to be doing this process. What we're hoping is that they'll be able to use the IPAC calculator to really prioritize who's being discharged, who has the highest risk of readmission, and then tackling those patients. Once we prove that that's effective, which we're confident we can, then we'll be seeing how we can get FTE from another area within nursing service or our own service to get an additional FTE, unused FTE for that second position. We are going to be having all of our case managers familiar with the process so that they can then also adapt to helping out, as well as we're very hopeful that there will be staff nurses that could do this on the weekend. And once we have everything ironed out and are comfortable with how we do it, it will hopefully become a part of what we do.
Lots of comments.
We're going to be introducing the role of a clinical nurse leader in certain areas, and I wonder, David, if you thought that this would be something that would fall under there in your area, because I think that's how we're going to probably do it in rehab, but just curious.
Where are you from? Which hospital? Oh, different unit.
Yeah, Deb Gitter, she's from rehab.
Right.
So for us, it's really under the case managers right now. We're looking at our clinical nurse leaders with the foresight of knowing that we're having so many retirees in the near future, and how are we going to manage units with less experienced people, is having those clinical nurse leaders working with the newer, lesser skilled nurses.
I might have missed this earlier, but I just wanted to know, have all the key stakeholders, the physicians, nurses, and members of the team taken a look at to ensure that that person's working to their highest level, that there isn't a task that can be shifted, like maybe the physician is doing something that a clerical person could be doing, or nurse. Do you see what I'm saying?
Yeah.
Just to kind of.
I see what you're saying. I think that's really getting at a lot of it too.
I think it gets catchy. It's catchy. Mary threw the doctors under the bus first. Now it's Denise. No, we're actually the ARC group is there are about 30 of us on the list, and about 15 to 20 of us that show up to the meeting, and we're kind of setting out the framework, and we're going to be then reaching out to the staff nurses, more of the hospitalists, to kind of see how, when we roll this out, how will it work, and what to make sure there isn't a lot of overlap. Though we've learned that having the doctors talk to the patient about discharge education, and then as well as the case managers and the staff nurses, so long as we're all speaking the same language, it's really a lot more powerful that way.
Yeah. Many hospitals, while we're waiting for the comment, many hospitals are choosing sort of the incremental approach. That is, they'll say, we're going to do it on these wards, We're going to do it for heart failure patients only. We're going to do it for just surgery or just high-risk patients based on some formula. Versus it sounds like you are more on the end of we're just jumping in and doing it. And that there's
kind of like what Denise said, we are pulling everyone together to discuss this, but it's hard for us, I think, so far in the group to say that there's a subset of our patients who don't need a very thorough discharge process.
Yeah, I think that's
so we're looking at definitely tackling those high-risk readmission patients, and then what does that mean for the patients who aren't as high risk, and what is it that we provide them, but definitely along the same line.
Yeah. Yeah, so it comes down to efficiency. How can we do this? I mean, it's hard to argue that people shouldn't go home with something that tells them what to do. It's hard to argue with that. So how can we do it most efficiently, it seems like?
As I understand it right now, and this might be wrong, the patient gets teaching from the medicine team, also from the nurse, and then again from the pharmacy. Is this booklet going to take the place of all or one of those? And are we not going to be doing the nursing discharge instructions and giving them a copy of the discharge instructions from the MD at this point? So were we not going to be doing this medication teaching anymore?
So let me say this. Nothing, I have to lay this out very clearly. Nothing changes yet.
Absolutely.
So,
I'm talking in the future, in the pretend.
Exactly. So in the future, and we'll need people like you to help us decide those questions, those answers. I don't foresee any one of us in any of the disciplines dropping an element of education that we're doing at the moment. We may do that differently. We may do less or more of it, and we may do it in a more organized fashion among all of the disciplines. But I know that the providers want to deliver their education, and I know that case managers need to be active with that, as well as social workers and nursing, definitely from the start of admission to discharge. So we'll work those bugs out as we go, but at this time, I don't see anything completely dropping or someone dropping one of those duties.
Okay.
But I don't make all the decisions.
Sure. I was just curious about the notes. We go through this whole big long note and go over it with them, but that would be very redundant to this booklet. So maybe it's the booklet we're going over. But I guess we'll find out.
We'll stay tuned. Yeah.
Stand by.
That's where I think process maps come in handy for that kind of thing. To see. What are the steps that are currently being done? And if you look, Dave, if you look on the Nebraska VA, if you look at the CMS website, I think they did their work through a QIO. There's a presentation from Nebraska on the web. On there, they have the best I've seen, process map of their discharge process, done very officially, with engineering symbols and that sort of thing, unlike how we did it. And that then the next slide is the steps of the discharge process that have been influenced by this new process, sort of like a failure modes effects analysis of how it's going to change things. And take a look at that, so we don't need to reinvent the wheel maybe so much, and how they did it. And this is a good example of that. This is the process that's happening, and then what can be replaced by a new process that hopefully will be more efficient.